Welcome to a crash course in pediatrics. My name is Dr. Shahid. I'm a general pediatrician and medical educator. CRASH stands for Clinical Reasoning and Analytical Skills with Shahid. The goal of this course is to teach clinical reasoning skills to medical students and residents. This is a series of lectures that will take you through several pediatric cases where you will learn how to critically think through a patient case and come up with a broad differential diagnosis. These cases are intended for educational purposes only and are not intended for actual patient care. The objectives of the crash course are listed here. So let's start our case. In this case, we have a 6-week-old African American female presenting with yellow eyes. Mom states that the patient's eyes have appeared yellow for the past 1 to 2 weeks. The patient has not been eating too well for the past 2 to 3 days and has been spitting up more than usual. She denies any fever, diarrhea, or respiratory symptoms. Mom is worried that the baby is not gaining weight. Past medical history is insignificant with no other hospitalizations. Her immunizations are up to date with the hepatitis B vaccine being given at birth. There are no known drug allergies. The birth history, she was full term, normal delivery, no complications. She had a birth weight of 3.4 kilograms. The 24-hour serum bilirubin level was 5.7. She usually drinks Similac with iron 3 ounces every 3 to 4 hours, but has not been feeding that well anymore. The social history includes that she lives with her mother, her father, and a 4-year-old sister. Family history, the father has GERD, the mother had gallstones and had her gallbladder removed about 2 years ago. There is a sister that had lactose intolerance as a baby, and a paternal grandfather has emphysema. Physical exam. The vitals include a temperature of 36.9, a heart rate of 160, respiratory rate of 52, blood pressure of 72/48, and a weight of 3.2 kilograms. In general, there is no acute distress. The skin exam shows slightly decreased turgor, but no rashes. HENT is atraumatic normocephalic head with slightly sunken fontanelle. Pupils are echo-round and reactive to light. The red reflex is present bilaterally. The sclera do appear icteric. The tympanic membranes are normal and the throat is normal. Lungs are clear to auscultation with no wheezing or crackles. Cardiac exam reveals a regular rate and rhythm with normal S1 and S2, a grade 2 out of 6 systolic ejection murmur heard best at the left upper sternal border that radiates to the axilla and back. Abdomen is soft, non-tender, no masses, with normal active bowel sounds. The liver is palpable 2 centimeters below the costal margin, but there is no splenomegaly. Normal female genitalia, extremities are normal. On neuroexam, she does appear to be having mild generalized hypotonia, but no focal deficits. Moreau reflex is present, and there is a positive Babinski's bilaterally. When I see a patient with jaundice, the first thing we need to establish is, does this patient have indirect hyperbilirubinemia or a direct hyperbilirubinemia? The differential diagnosis for each one is very different. So the first thing I would do in this patient is get some initial labs like LFTs and a CBC to help me determine that. This is our patient's initial labs. The CBC is essentially normal. The patient does have a little bit of an anemia, which might be related to physiologic nadir since the patient is 6 weeks of age. The electrolytes are normal. LFTs, AST is elevated at 176, ALT is also elevated at 202, the ALK Phos is high at 640, the PT, PTT are within normal. The total bilirubin is 5.8, with a direct bilirubin of 4.7, and the albumin is 2.9. So this tells me that the patient has a direct hyperbilirubinemia with a little bit of hepatocellular damage given the elevated AST and ALT. The ALK Phos is a little bit elevated, suggestive of an obstructive type of process. The albumin is essentially normal and PT, PGT are normal, which means the synthetic function of the liver is normal at this point. So to summarize this case, we have a 6-week-old coming with jaundice found to have direct hyperbilirubinemia. Direct hyperbilirubinemia is defined as having a direct bilirubin greater than 1 if the total serum bilirubin is less than 5, or greater than 20% of the total serum bilirubin if the total serum bili is greater than 5. This patient also has increased LFTs, possibly anemia, which is secondary to physiologic nadir. The patient has some poor weight gain and has a murmur at the left upper sternal border and possible hepatomegaly. So in this case, we have a 6-week-old coming in with direct hyperbilirubinemia. So let's create a differential diagnosis for direct hyperbilirubinemia, especially in a young infant. So the first category we want to start with is infectious causes. So let's think about what are some of the infections that can cause direct hyperbilirubinemia in a young child. In a newborn, in a young infant, one of the categories under infection is actually torch infections. So thinking of the congenital infections like toxoplasmosis, CMV, and others under the category of torch infections can cause you to have direct hyperbilirubinemia right at birth. Probably a little bit less likely in the 6-week-old, but still something to consider then. Other infections that you have to think about are the other infections that can involve the liver itself. So you can have other things like hepatitis A, hepatitis B, and hepatitis C if the mom had it. Other things, other viral infections that they could have gotten that maybe were not congenital infections but were acquired include these hepatitis causes such as Hep A, but possibly congenitally Hep B and Hep C. But other things to consider, we mentioned CMV already, EBV, parvo. All of these can actually give you an acquired infection in which you can have direct hyperbilirubinemia. Other infections that you can get congenitally, other than Hep A, B, and C, includes something like HIV that can also give you a direct hyperbilirubinemia. Another type of infection that you have to think about that sometimes we don't always consider because it doesn't involve the liver itself, but in young kids, a UTI and overall sepsis can also cause you to have direct hyperbilirubinemia. So that's a consideration in this young infant coming in with jaundice and direct hyperbilirubinemia, that you might have a UTI as well. So these are some of the infections you have to consider at this age that might cause you to have a direct hyperbilirubinemia. The next category I think is a very important category, and that is obstructions. Obstructions of the liver and the biliary tract that can lead you to have direct hyperbilirubinemia. And this is a major consideration in this child because the child has increased alk-Phos and has some increased LFTs and has the direct hyperbilirubinemia. One of the urgent diagnoses that has to be made in a young child that can be from an obstruction is biliary atresia. This is something that has to be considered in this age of a child urgently. Biliary atresia, basically you have atresia of the outflow tract from the liver, and you cannot excrete the bilirubin, so that causes you to have hepatocellular damage. Typically this presents around 3 to 4 weeks of age, where the child starts to have poor feeding and vomiting and poor weight gain, and then is jaundice, has a direct hyperbilirubinemia, can have acolic stools, and it's important to make this diagnosis early on, and you have to surgically correct it. You have to bypass the obstruction, and the surgery for this is called a Kasai procedure. So you need to do a Kasai procedure to bypass the obstruction. And ideally you want to do the Kasai procedure within 45 to 60 days of birth, so within about 2 months of birth, in order to prevent permanent damage to the liver. So this is a 6-week-old child, about 42 days of age. So biliary atresia is a very important consideration on this child that has to be looked into, has to be addressed and then treated urgently if you want to minimize permanent damage to the liver. So this is a huge consideration on the differential of this child is biliary atresia. And this is an extrahepatic obstruction. So it's atresia of the biliary tract coming out of the liver, so it's considered extrahepatic biliary obstruction. So this is a major consideration in this type of a child that's coming in at this age with the findings of the direct hyperbilirubinemia and the other findings that this little child has. Another obstructive process that you have to consider is something called a choledochal cyst. So that's something that is always considered on a young infant coming in with direct hyperbilirubinemia, where you basically have a cyst in the biliary tract that's causing an obstructive process and causing the direct hyperbilirubinemia. So that's something to consider in this type of a child as well. Other obstructions, another entity is called Alagille Syndrome. So that's something to be considered as well in a child coming in with direct hyperbilirubinemia, Alagille Syndrome. And this is basically intrahepatic paucity of bile ducts. So you have a paucity of bile ducts in the liver, so it's intrahepatic paucity of bile ducts, so you don't have a lot of bile ducts, so then you don't get good flow, and it presents with an obstructive type of process. So this is something to consider as well on the young baby, infant, child coming in with direct hyperbilirubinemia, and there's other findings of the syndrome that can help you identify that as well. Then the last entity is called Beiler Disease. This is something else that you can consider, and this is a familial type of process. Again, it's intrahepatic, and it's a progressive intrahepatic cholestasis that is familial. So typically you get a history of family members having cholestasis and direct hyperbilirubinemia. So these are some of the things that you must consider on a young infant or a child coming in with direct hyperbilirubinemia in the infection category and in the obstruction category as the child comes in. The next category that is, I think, very important to consider is the metabolic category. And there's a lot of things under metabolic, which actually then, let's put this over here, because there's going to be several things I'm going to write under metabolic causes of direct hyperbilirubinemia. So metabolic causes is another major consideration for direct hyperbilirubinemia, especially in the younger infant, because most metabolic diseases present early on. So one of the things that you have to definitely consider early on at this age under metabolic is galactosemia. So this is a major consideration in a young infant coming in with direct hyperbilirubinemia. It's typically tested for in the newborn screen, so you can usually identify it at that age, but sometimes it can be missed, or there could be issues with that. So it's still a major consideration on a 6-week-old child, but particularly if the child had been a little bit younger, this still would be a major consideration in a younger child, and even at 6 weeks of age, something to consider. So basically, you cannot break down lactose, because lactose is broken down into galactose and also glucose, and then that galactose cannot be further broken down because you have a deficiency in the GALT enzyme. The GALT enzyme is galactose 1-phosphate uridyl transferase, so GALT, G-A-L-T, that's the enzyme that is deficient. So you have accumulation of galactose. So basically, if you're feeding a lactose type of formula, breast milk, and also formulas that are lactose-based as the sugar source, then you can't break that down, or the galactose cannot be broken down further from the lactose, and then you have accumulation of galactose that causes the liver injury then. So galactose is a huge consideration, especially on this child coming in with poor feeding, poor weight gain, and direct hyperbilirubinemia. Now it's interesting that the sibling and the sister of this child also was diagnosed with a, quote, lactose intolerance when she was younger, and was switched to a soy formula. So it's possible maybe that the sister had galactosemia and was actually treated without a formal diagnosis by being switched to soy formula, because soy formula usually has a different type of sugar source, like sucrose or corn syrup or something other than lactose. So the treatment for galactosemia is usually some sort of soy formula or some sort of formula that is not lactose based. So it's interesting that the sister was on soy formula when she had vomiting and poor weight gain in infancy. So maybe this child also has galactosemia and is now presenting with this as well. So galactosemia is a major consideration in this age because if you don't treat it quickly, you can start to have liver damage and liver injury. and accumulation of lactose, and the other things that it can present with, or you can develop, are cataracts, you can have mental retardation, and then a big thing that the boards love to ask about is about like a 3 or 4 week old child coming in with jaundice is found to have a urinary tract infection with E. coli, and they can develop urosepsis. So patients with galactosemia can develop E. coli, UTIs, and urosepsis. They're at risk for that because they actually have reducing substances in the urine because they're not breaking down the sugar properly. They have positive reducing substances in the urine, and that causes the child to be at risk for a UTI with E. coli and further develop urosepsis. So if you have a 3-week-old, 4-week-old coming in with UTI and is found to have E. coli and maybe even urosepsis, think about galactosemia as a potential underlying reason for them to have that setup of these findings and the direct hyperbilirubinemia. So I think that's a major consideration. And then moving along on other causes of galactosemia, metabolic diseases in addition to galactosemia, we can start to list a few of them. So let's list another one that gives you positive reducing substances. So that's fructosemia. So fructosemia can give you positive reducing substances and a direct hyperbilirubinemia as well. So this is basically you can't break down fructose and you have accumulation of that sugar. So this also gives you positive reducing substances in the urine. Typically this presents a little bit later than 6 weeks of age, usually about 4 or 5 months of age when children are introduced to juices. So when they start drinking like apple juice and other juices because fruits will contain fructose. So when you introduce fruit juices around 4 or 5 months of age, that's when a child with fructosemia potentially can present at that age. The next thing under metabolic we can mention is tyrosinemia. So that's another entity that can give you direct hyperbilirubinemia. It's very uncommon, but still something to consider. So that could be a metabolic cause of direct hyperbilirubinemia. Another one includes alpha-1 antitrypsin deficiency. Okay, so after alpha-1 antitrypsin disease, other things that you can consider under metabolic causes would be something like Wilson's disease. So Wilson's disease, the classic vignette that you'll see like on your board exams and then also potentially in real patients is going to be a little bit older. They won't be infants. They're usually a little bit older, maybe 9 years of age, 12 years of age, adolescents, and they're coming in with the jaundice and they have the direct hyperbilirubinemia. But they typically will come in with other neurologic type of findings. So they may have ataxia, they may have an intention tremor, and then the classic finding when you do a slit lamp exam for their eyes is that they're going to have the Kaiser-Fleischer rings. So that's how you would diagnose Wilson's disease. But still on the differential for direct hyperbilirubinemia, maybe in the younger kids, but definitely in older kids then. And then again, getting back to some of the younger kids, maybe different type of storage diseases. So different like glycogen storage diseases, Gaucher's disease, Niemann-Pick disease. So there's different type of storage diseases that can cause accumulation of different byproducts in the liver and give you hepatocellular damage and then also a direct hyperbilirubinemia then. And then other things, other congenital causes. So you can have Dugan-Johnson syndrome, you can have Rotor syndrome. So those are other entities that can also present with a direct hyperbilirubinemia. So these are other entities to consider that we can kind of lump under the metabolic category as well. And occasionally then you can have other things like cystic fibrosis can present with liver involvement. Typically that would be more pancreatic involvement and poor weight gain and respiratory, but it can also involve the liver as well. After cystic fibrosis, you might have other metabolic things where you get storage of maybe iron in the liver, so you could have hemochromatosis, kind of rare, but still something that you can consider as well. And then other type of things like urea cycle defects. So there's lots of metabolic things that can give you direct hyperbilirubinemia that you have to consider. But I think this is a pretty good list, and I think some of the big ones on this child that you might consider would be galactosemia, maybe some of the storage diseases, glycogen storage disease, or one of those type of metabolic processes, maybe Duken-Johnson, Rotor, things like that are probably things that you might consider in this child as well then. And then moving on to the next category, after infection, obstruction, and metabolic, the next thing we can think about is malignancy, so we'll write that here. So different malignancies can also give you liver infiltration and hepatocellular damage, and therefore direct hyperbilirubinemia. So the big things to consider on this one will be things like leukemia, so ALL and leukemia, where you have liver infiltration. And then another entity is called Langerhans cell histiocytosis, is another malignancy that can cause infiltration of the histocytes into the liver, and a direct hyperbilirubinemia from hepatocellular damage. And then another one to consider that you can actually have in young kids is a type of neuroblastoma called 4S. So neuroblastoma 4S. 4S stands for special. So it's stage 4, but it's S for special. So this is an interesting type of neuroblastoma that can present in infancy and congenitally and right at birth, where you have neuroblastoma, but it's actually confined to your liver and your spleen, and in that area, so you can present with a large liver and a large spleen. And it's actually very sensitive to chemotherapy, so the prognosis is actually quite good, even though it's stage 4. It's a 4S, 4 special, and this neuroblastoma can be treated effectively with chemotherapy and can present, and it doesn't really present with an actual mass, but actually presents with more infiltration of your liver and your spleen with these malignant cells, and can be present very early on in life as well. And then there's other entities like different drugs, different medications can cause you to have it, right? So there's different antibiotics. Acetaminophen in large amounts can do that. Bactrim or sulfa drugs can do it. A lot of the anticonvulsants can cause you to have increased LFTs, and also direct hyperbilirubinemia. So there's a lot of different things that can do it as well. And then there's other categories of just like idiopathic, right? So there's idiopathic neonatal cholestasis. So there's different idiopathic causes, idiopathic neonatal cholestasis. There's autoimmune hepatitis. So there's various things. This young child had been on TPN or Hyperal from prematurity and had a central line and was getting Hyperal. That can cause neonatal cholestasis from the TPN. So there's a few other things that you'd have to consider, but these are, I think, some of the big categories of causes of direct hyperbilirubinemia that has to be considered in this child. So again, given the age, you have to think about infections like torch and other type of congenital and acquired infections, UTI and sepsis, especially if you're worried about possibly galactosemia. And then the obstructive processes, I think, are all very important to consider. And then some of the malignancies, and then obviously the metabolic things like we mentioned with the storage diseases and other congenital causes of direct hyperbilirubinemia. So this is the full differential of how to approach a young child with direct hyperbilirubinemia. And now let's see how this child's case unfolds and what type of workup was done, and how a final diagnosis was ultimately made on this child then. Given this differential diagnosis and our patient with direct hyperbilirubinemia, I would start off with an ultrasound of the liver and gallbladder. The reason you want to get that is to look for obstructive processes, to look for a choledochal cyst, and to look at the size of the liver, and also if they have biliary atresia, then a lot of times they have an absent gallbladder, or kind of a smaller gallbladder that didn't form properly because of the biliary atresia. So an ultrasound will be the first thing that you most likely do in this patient. So our patient had an ultrasound of the gallbladder and liver, and the liver was a little bit enlarged with some increased echogenicity consistent with some inflammation. the patient did have a gallbladder that was visualized on the ultrasound, so that potentially makes biliary atresia a little bit less likely. You haven't ruled it out with just an ultrasound, but the gallbladder being present makes it maybe a little bit less likely, but still something to think about. The patient did not have a choledochal cyst, so we ruled that out. So the ultrasound was helpful in some ways. So now that we have that finding, biliary atresia is lower on the list, but still a possibility. And then there's other things like Alagille Syndrome and other things that you're still considering. So because we haven't totally ruled out biliary atresia based on the ultrasound, the next test that many times is done is a nuclear medicine test called a Highness Scan. So this is for biliary atresia. So you do something called a Highness Scan. HIDA is a long name for some radioactive isotope, basically, that is injected into the bloodstream, is then taken up by the hepatocytes, and then is excreted into the biliary system, and then you can take images through nuclear medicine scanning to see if that radioactive isotope is first of all taken up in the liver, and then if it's excreted into the small bowel, to look for any type of obstructive type of process that might suggest biliary atresia. So our patient did have a Highness scan, and it showed uptake of the radioactive isotope into the liver, and then it showed some delayed excretion of the isotope into the small bowel. It didn't show absence of excretion. If there was absence of excretion, then that would be consistent with biliary atresia, because then you would have such a severe obstruction that you cannot excrete that radioactive isotope into the small bowel. So our patient had some excretion into the small bowel, and it was a little bit delayed. Based on that, the patient ultimately ended up having a liver biopsy to help differentiate between biliary atresia and possible Alagille syndrome. So the patient had a liver biopsy, and the liver biopsy helped us make a confirmatory diagnosis. If you have biliary atresia, the liver biopsy will show a hyperproliferation of bile ducts. That's the liver's way of trying to compensate for the biliary atresia. So when you do a liver biopsy, you will see hyperproliferation of bile ducts. That will be consistent with biliary atresia. If you have Alagille syndrome, then the biopsy is going to show a paucity of intrahepatic bile ducts, because that's by definition what Alagille syndrome is a paucity of intrahepatic bile ducts. So our patient had a liver biopsy, and it showed a paucity of intrahepatic bile ducts consistent with Alagille syndrome. So our patient was ultimately diagnosed with Alagille syndrome, and had actually other findings on exam that would be potentially consistent with that. There is genetic testing that you can do to diagnose Alagille syndrome, but the clinical findings of Alagille syndrome, there's 5 components of Alagille syndrome. The first one is the paucity of intrahepatic bile ducts, so that's number 1. Number 2, you can have peripheral pulmonic stenosis. So our patient actually had a murmur at the left upper sternal border that was radiating to the back and the axilla, consistent with PPS, so that is a finding of Alagille syndrome. Another component of Alagille syndrome is if you did an x-ray, like a chest x-ray or actually an x-ray of the spine, you would see butterfly-shaped vertebral bodies. So a part of Alagille syndrome is butterfly-shaped vertebral bodies. And then there's an eye finding that the boards love to ask about when they ask about Alagille syndrome and its components. And that's called, for Alagille syndrome, the eye finding is called posterior embryotoxin. So on embryotoxin. So that is the eye finding of Alagille syndrome that an ophthalmologist makes on slit lamp exam. They would diagnose or let's see something called posterior embryo toxin, and that is the eye finding of Alagille syndrome. And then the other component, the fifth component, is basically dysmorphic facies. So the 5 components of Alagille syndrome include the paucity of intrahepatic bile ducts. That's number 1. Number 2 is the cardiac finding of peripheral pulmonic stenosis. Number 3 is butterfly-shaped vertebral bodies. Number 4 is the eye finding of posterior embryo toxin. Number 5 is dysmorphic facies, where you have kind of a round nose and maybe a more prominent forehead. So very subtle findings of that. And then, like I said, there's genetic testing that can be done to confirm Alagille syndrome as well then. So ultimately, our patient ended up having Alagille syndrome and was diagnosed with that based on these findings. The treatment of Alagille syndrome is basically supportive. So as their liver function, if it does deteriorate, you obviously supplement with a fat-soluble vitamin, so vitamin A, D, E, and K, the fat-soluble vitamins that you would supplement for any patient that has some liver damage or liver failure to help with absorption of fat-soluble vitamins. And then you can also give medications that will promote excretion of bilirubin or excretion of bile from the liver. So there's different meds that can do that. One that is commonly used is ursodeoxychoic acid, commonly called, brand name is called Actigol. That's one of the meds that can help promote excretion of bile from the liver, and then there's other medications that can be done as well. So the treatment really is supportive, and depending on how much of a paucity of bile ducts patients have, as they get older, sometimes they can actually develop more liver damage and liver failure because they can't keep up with the needs, and they don't have enough bile ducts to keep up with that. So some patients actually go into liver failure and require liver transplantation down the road as well. So it can be a very devastating disease to have. So to wrap up this case then, we have this 6-week-old coming with a direct hyperbilirubinemia that you have to consider some infections. You have to consider biliary atresia, Alagille syndrome, choledochal cyst, so the obstructive processes, a lot of the metabolic things, especially like Galactosemia and some of the other ones, and then other causes of it as well, and then do the appropriate workup to make a diagnosis as rapidly as possible. So I think that's very, very important. So again, these CRASH cases really focus on clinical reasoning and analytical skills and thinking through a patient, thinking through a differential diagnosis, trying to interpret the findings, trying to interpret the labs. The focus is not to give a lecture on any one of these topics. So now that you know what are some of the things you might consider, now you can go back and read about some of these topics to reinforce your learning and your education. Again, the focus is more on to develop a differential diagnosis, and now you can go back and read more about Alagille syndrome, read about choledochal cyst, biliary atresia, and galactosemia, but then also just kind of read about direct hyperbilirubinemia and the different causes, and use this case to read about all those different entities. So with that, we'll end this session, and I want to thank you for viewing this CRASH case, and look forward to seeing you at future CRASH cases as well.